And along with Vinay Mayo, our CME coordinator, we welcome you to our program this evening, Controversies in Trauma Management. The program this evening provides 2 hours of Physician Category 1 AMA CME credit, as well as Virginia Nurses Association 2 hours of CE credit, including time for pharmacology CEs for the nurses. Sovah Health is accredited by the Southern States Collaborative CME organization as a recognized accreditor. It's also accredited by the American Nurses Credentialing Centers Commission on Accreditation through the Virginia Nurses Association. The program was developed to promote certain desirable physician attributes, including our providing patient centered care and always using evidence based medicine practice. This program was developed by the two team leaders in our ER in Martinsville and Danville. That's Dr. Michelle Mitchell and Dr. Bruce Bruzak in Martinsville. They, through their own survey of the ER staff, identified the educational topics that we'll be discussing this evening. Dr. Kern, Dr. Byrne, myself, and members of the Sovah Health CME Committee have no commercial relationships to report to you this evening, and there is no commercial support for this program this evening either. It is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the local urology nephrology practice in Danville, made a significant contribution to the medical center upon his retirement. This has provided a significant endowment to support speaker honoraria for medical education for all types of healthcare providers and allied healthcare professionals in our community. This evening, at the end of the program, we will place two things in the chat for you to get an evaluation form. There will be a QR code as well as an overt link you can click on to take you to an evaluation form. We ask everyone to please complete the form, and we utilize that as a mechanism to provide you your CME certificate of attendance. So when you fill out the form, it will ask you to re-enter your name and your email. Please give us your full name. That is the name that will appear on your CME certificate. Please no short names or nicknames, etc. We also call your attention to the 7 questions that you'll see on the form. Question 4 is, what changes will you make in your practice based on what you learned this evening? And that's for everyone. That's not just for the physicians or on the call or providers. Take a few minutes, fill it out, and give us your thoughts. We also, if you're sharing the call tonight with a colleague, so only one of you are logged on, please let one of us know that so we can get a certificate to the other person who's on the call with you. For the medical residents, our medical residents on the call, you do not have to collect your CME certificates. Your respective coordinators are told if you attended and maintain that. Nurse practitioners and nurses must submit an eval form in order to receive credit for their participation. So please be sure you do that. Every week when we do these programs, I like to take a moment to thank the people that make this possible beyond my efforts, which include Vinay Mayo, our coordinator, and Pam Cordell, who is the Market Nursing Education Director. They really are the ones that make all this happen each time we do a program. I know questions from both speakers are encouraged, and we'll be monitoring the chat. Now, I want to give you a heads up. We're going to be doing something a little bit different tonight. I know Dr. Burns and Dr. Kearns are going to actually be asking you to tell them who you are on the call. So I urge you, please, please, please cooperate when they ask you to do that. It will make for a much, much richer experience for us on the call. When you are providing information, responding back, or stating a question, once you've done that, please mute your phone so we don't get feedback as the speaker answers that. Let me highlight for you what will be coming in July. We had initially set up July as a GI topic month. And so we had scheduled colon cancer screening with Dr. Dez from Duke Gastroenterology on the 9th. And then 2 weeks later, an update on inflammatory bowel disease with Dr. Wong, also from Duke Gastroenterology. However, with the emerging Ebola viral concern in Africa, we thought it would be appropriate to have someone talk with us about Ebola and the other, if you will, emerging viral pathogens currently in the world, since this affects so many people. And while it's said to be low risk, we know from COVID that this thing can get out of hand. So we're fortunate that Dr. Cameron Wolf, who leads the Duke Healthcare System's Emerging Pathogens Unit, in other words, he leads the group that decides how a healthcare system should respond to any sort of epidemic, et cetera. So we're fortunate he's going to be doing a program on July 16th to talk about that. Tonight, I'm delighted to have two outstanding speakers from UVA's emergency room system and the Blue Ridge Poison Control Center. They're going to do the presentation together as opposed to one following the other. And so let me briefly introduce them to you. Dr. Abigail Kearns began her educational journey with her bachelor's degree in biology and a minor in history at the West Virginia University. She followed that with her other major training, receiving her MD as a global health track scholar at West Virginia, and then completing an internal medicine internship. She went to the Allegheny General Hospital in Pittsburgh, which is a major trauma center for emergency medicine residencies, and that was followed by a medical toxicology fellowship at the UVA School of Medicine. She's had numerous academic awards. She is core faculty for students, residents, and fellows in medical toxicology at UVA, and she has numerous publications in toxicology subjects. Dr. Brendan Byrne is also a member of the ER staff at the UVA. He began at the University of Michigan with his undergraduate degree, followed by his MD from Wayne State University School of Medicine. He's had an active military career in the Navy and continues as an active reservist in the Naval Reserve. He completed his internship at Portsmouth Naval Hospital and then his emergency medicine residency back at Wayne State University in Detroit. He also is certified and has completed training as a diving medical officer and an underseas medical officer through the Naval Educational Institute. He has experience in publications in not only ER medicine, but healthcare policy, medical ethics. He leads a pre-hospital EMS training program in the counties, Albemarle County, where UVA resides. In addition, he is the medical director of the Navy Special Warfare, Special Operations Tactical Medic Group. That is, he trains the Navy SEALs in medic care programs for their entire set of teams. And then most recently, he was a member of the Artemis II Naval Recovery Team. He was aboard the USS John P. Murtha when the Artemis II capsule was recovered, and the astronauts were in great shape, and basically a really remarkable experience. Dr. Burns, we thank you for your service, and we thank you and Dr. Kearns for making yourself available for this really great program this evening. So, Dr. Burns, if you bring up your slides, mine will drop off, and it's time to go. Thanks so much.
Very good. Dr. Moore, thank you so much for the very generous introduction. We really appreciate it. Okay, so let's hopefully you can see our slides, and now you can see what we were nerding out about with our chemical structure, because yeah, that's what you do in an ivory tower. You nerd out about stuff. So, you know, like, I wanted to start off first of all with a thank you for the invitation, a thank you for the for all the hard work that Vinny, you put in herding our cats for all the paperwork that we're, you know, clearly so good at doing. So thank you. We really appreciate it. We're happy and proud to be here. You know, I recognize there's 37 of you in the room. So we're going to let you guess which of us is Statler and which is Waldorf. And we kind of wanted to get an idea who we're talking about. You know, can I get a show of hands? If you can raise your hand on the little reaction button, if you are a resident. All right, hearing none. Show of hands for all of our nurse colleagues. Cool.
So few, yeah.
5, yeah. Okay.
Another thing that'd be interesting to know as we're kind of thinking about these things. So Dr. Bird and I both teach ATLS, and in fact, we're teaching it earlier today together. A lot of the concepts that we'll be talking about are ATLS concepts. Has anybody in the room formally done their ATLS training? So advanced trauma, life support. It's like ATLS, but a 2-day course and really just trauma support.
I'm seeing 7.
Okay.
Okay.
All right, great.
So
yeah.
You know, kind of good experience around the room. Oh, long back. Yeah.
Yep.
Yeah. Trust me. I recently let my ACLS and PALS instructor certification lapse, and I realized that I'd been certified since like 08, and I thought that wasn't that long ago. And apparently,
3 years.
Yeah.
3 years.
Yeah.
So. But we'll be building a lot of the concepts off of ATLS, doing a little bit more deeper dives than some of the concepts that they present into it. And then it'll be a little bit of a refresher of just kind of general ideas for trauma support too.
So, basic things being basic, I appreciate that we have that you kicked us off, Dr. Moore, with no financial. We all have our various committee roles. We have our various academic activities, and so really, aside from that, no, the beauty of being an academic physician is you're a public servant and you get paid like a public servant, not like a private practice doc. So we don't really get to generate a whole lot of financial conflicts. I do have to be very explicit, though, that these are academic opinions. These are opinions based on the best evidence that we could find. These are not policy descriptions for either the University of Virginia, the State of Virginia, the Department of the Navy, the Department of War, nor any entity in the United States government. And, I have to unfortunately explicitly say that. So please bear with us. Okay. Going over some things. Our goal is to kick this back and forth. Our goal is to be very informal. So please do come up on the net, either raise a hand or pop in if you've got questions. We'd love to get to know you. So, you guys, your colleagues are not that far away. So please introduce yourself and fire away if you have a question, right? But, talking about problems, right? The real problem here is the dilemmas that you face in management of patients, right? When do you manage an airway? When do you hold? All right, ATLS is kind of changing their stance. You'll hear surgeons say a lot of very interesting things about this, and then delayed sequence intubation has kind of replaced RSI in most of the recent literature. And then, what do you resuscitate someone with? What do you do and why? When resuscitation doesn't work, what do? Do you manage the blood pressure? Do you let it drift? Do you use vasopressors instead? Or, when all else fails and you have to penetrate the thoracic cavity, how do you do it? So that's our goals, and that's what we're going to do. So without further ado, we've got some inbuilt breaks here. Mm-hmm. You guys need a break, give us a raise or duck off, do your thing. But let's talk about our first controversy, right? So I don't know what you're practicing for airways. Mm-hmm. I certainly remember when we started, it was this super rigid, like, hey, you show up, you are going to RSI the patient. This is a trauma thing, mm-hmm. And we went back, you had to do burp, right? Because cricoid pressure was the thing that would definitely save us from all the aspiration events with all these horrible traumas. And it was a very rigid, you will give a non-depolarizing neuromuscular agent. You will give a sedative. Etomidate was relatively new on the market. It was still kind of primarily propofol. We were still using barbs at the time. Yeah, maybe I'm dating myself. Yeah. And that's kind of progressed a little bit, but we were, it's come a long way. So rather than this very highly scripted time regimented thing where the question was, how quickly can you get this stilted dance done?
Mm-hmm.
I have to be honest, after graduating residency, I stopped doing it
Mm-hmm.
relatively quickly. And I don't think it was just kind of lazy practice. I think, what I was trying to do was to develop the finesse. And full disclosure, my wife's an anesthesiologist. So she's very, very thoughtful and very finessey as she titrates down to the milligram, and she'll intubate somebody with 40 prop, and
Mm-hmm.
we don't do that.
No.
I had a girl talking to me after 200 prop the other day.
Yeah.
But I would argue that my clinical practice really has been some evolution of DSI ever since graduation.
Yeah, I think that, one of the big things to recognize is that these are generally urgent airways, but not like true emergent airways. And I was intubating with a resident recently, and he was just talking to himself, talking him through a really challenging airway, Matt Britton. And he's just talking to himself, and he goes, fast is slow, slow is fast, fast is slow, slow is fast. And I think that kind of like really gets to the crux of the issue is that like with these airways, if you think about things and you use the correct pharmacology and think about your medications, it's going to be a much better outcome for everybody in the room, and really the patient is going to have a better outcome for this.
Yeah, absolutely. So that being said, ATLS in the 11th edition. 11th edition just came out, right? This is fresh off the presses. New classes are now being taught as of February in the 11th edition. Up until then, the 10th edition was optional, and the 10th hadn't been updated since 18. So it was a relatively long edition. But the 11th edition, kind of in the compendium of changes, says, hey, the concept of applying basic airway while initiating volume resuscitation is introduced, right? Mm-hmm. So really, what people noticed is you were having a peri-induction cardiovascular collapse. Mm-hmm. And then that wasn't bad. It wasn't good.
Yeah.
And so they said, hey, let's be a little smarter. I haven't seen that in my practice. I don't think that's necessarily because of any personal characteristics. Mm-hmm. Maybe it's because I've gotten lucky, mm-hmm. or maybe it's selection bias, mm-hmm. or maybe it's my teachers were more finessey about that. I don't know. Mm-hmm. And they talked about adjunctive vasopressors, and we'll talk about vasopressors in different contexts later. But pressor support happens, especially when you give some patholysis. Mm-hmm. The one thing they do though is they say, look, rapid sequence intubation in this context, per this course, they've taken it upon themselves to redefine the meaning of the term, which I was a little surprised at for a bunch of not airway experts. And so they're talking more about taking medication administration rapidly instead of rapid kind of slamming of.
Danae, we lost audio.
I'm calling them back to log on.
The call cannot be completed as dialed. Please consult.
All right. And we're back.
Great.
Okay. Apologies about the comms issues, guys. Appreciate your patience. So, look, I think we're beating the dead horse on this one now, right? So ATLS has recognized changes. But that really begs the question, where does this actually come from? What was the literature that supported this? And the seminal paper in this kind of venue was Scott Weingart's 2014 paper when he introduced the term delayed sequence intubation. There's been a lot of work about it, but the central premise of this paper and DSI was that this is a new technique, primarily based more off the sequencing of drug administration, pre-oxygenation, and then airway manipulation in order to optimize adequate pre-oxygenation, in order to optimize mental status, cerebral perfusion, and minimize the risk of intubation collapse. So, it was a smart paper, I thought. I think it kind of reflected my practice, really. He's Scott Weingart, so he's smarter and he's better about describing it. So, where does that take us now? What has happened since 14 is kind of a sequence, and more importantly, not only a sequence, but a persistent sequence of talks that have now penetrated both the ER world and the sorry, that was annoying. The ER world and the pre-hospital realm. And what you see is a bunch of guys talking about it, right? And we left the links here, and we're happy to disseminate these slides to you so that you guys can go see what we were talking about. But, the Life in the Fast Lane guys, they're a group of critical care and ER docs out of Australia, and they do a really wonderful job of sequencing modern and kind of breaking it down and chunking modern advances in emergency medicine. Scott Weingart's MCRIT podcast and site, he does a great blog there and he talks about it. So we've given you a bunch of options here so you guys can go look at why this is important and whether this really kind of resonates with you. I don't know, like I said, I think it does for me. What about you?
Yeah, I think it represents a departure from what people have been doing for maybe like the past 10, 20 years. By and large, we're getting a little bit less aggressive with, I think, giving specific medications at specific times. For instance, we're a little bit more inclined to do awake intubations or intubations where we don't necessarily paralyze the patient. So I think that we're just getting a little bit less aggressive with saying, A, then B. And I think that is part of that whole discussion. I am a huge fan of optimizing a patient's physiologic status before intubating patients. And I tell the residents, I say, intubating a patient should be the scariest thing you do. Not because of getting the tube in the cords. That's easy. You can get a tube in any cord. But what's going to happen is you're going to change the patient's physiology, right? You're going from basically a negative pressure ventilation to a positive pressure ventilation. You're giving them a bunch of medications that are going to drop their sympathetics. So you're changing this patient completely. And I think that like doing this in a delayed manner just gives a little bit more respect and thought to like what we are actually doing physiologically. It makes sense. And of course, there are times that, you don't have necessarily the time or the bandwidth to really switch into this, but it's just a general trend is what it seems like. So.
And, give a medication, let the medication do its job.
Yeah.
Make sure it is doing its job and it's doing its job in the way you like it to do it.
Yeah.
And that you're not seeing a downtrend and that you can intervene and counteract, right? Whether you need to give a little pressor support, whether, it's a push dose epi if you need some inotropy, whether it's a push dose phenyl if you're just worried about SVR, you got options.
And we'll talk about pressors at the end of the lecture. Really, we're going to dive into the pressor component. And as a toxicologist, I could talk about medications, until 7 a.m. tomorrow for you guys, but we won't do that. But really, like, there's some appreciation for the medications and giving them in a little bit more delayed manner.
Yeah. So. All right. So, look, let's kind of go over this for those of you, again, not everybody is got the frequency of intubation, and you see that in clinical practice with the advent of BiPAP. It's just not always a common thing. We're trying to look for other less invasive ways. So if you're not intubating, I do want to take a minute and for those of you who are, please forgive me, I'm not attempting to be pedantic, but the Life in the Fast Lane guys kind of did a good job describing here what the kind of sequenced procedure is for delayed sequence and what that really looks like as compared with RSI. And as you notice, this is a much more complex algorithm perhaps than just pre-oxygenate, give sedative, give non-depolarizer, give depolarizing agent, give analgesics, put tube in hole. So identify an agitated patient And really, if you're looking at ketamine, you are given a sedative dose ketamine. Oh, hello, boss. Hi, honey. Sorry for the cameo, folks. And then pre-oxygenate the patient best you can, whether it's by cannula, whether it's by non-rebreather. They make a very great point, an interesting point, right? How many times have you laid absolutely flat and attempted to breathe? Your lung physiology is optimized for recruitment in the vertical position. So a supine position really is harder to breathe and harder to oxygenate across. And then, as needed, you either pre-oxygenate for a while, or, if that's not working and you've got a bigger problem, you might need to give them a little positive pressure. It's the thing. Then you get to decide, do they still really need it? Or have you given enough pressure that you're okay? And either stop intubation and figure something else, or push your paralytic and go for the gusto. And that really is a distillation of how Scott Weingart originally described it. And again, I think it's a very kind of more thoughtful, more artful way of doing it. So, I leave this for you guys, and hopefully this will help kind of inform your practice, because I would argue this is pretty reflective of how I choose to proceed.
Yeah, and I think that's something that I have more appreciation for now is the amount of dead space and how that can contribute to somebody desatting quickly. Really when you have this, I think, delayed sequence intubation, I don't know if you're going to jump into this or not, but if you can blast them with oxygen, right, and try to do a little bit of denitrogenation and get rid of some of that dead space, you can buy yourself more time if this is going to be a really challenging intubation. So typically what I've been, my practice recently is more putting them on the non-rebreather, depending on their situation, and then blasting it. It says 15 liters. I go stand by it and crank it past 15 liters. It goes way above that. Okay. And if you can put the patient on that for a little bit before you decide to paralyze them, you have bought yourself some extra time when you paralyze them eventually, right? So all that dead space has been, you got some oxygen in there, and it's definitely a little bit more of a safe intubation in my mind. So.
Oh, agreed. Yeah. And, not only that, as you pre-soak them and you change, right? So if you look at their PPO2 at the cellular alveolar level, and forgive me, this is my hyperbaricist nerdy side coming out, right? So look at their PPO2 as it comes out, and then you super saturate them. And even without positive baropressure, without really true, I'm not talking the kind of pressure you can deliver with a BiPAP or with a fan. I'm talking hyperbaric oxygen. And without that, multi-atmosphere pressure where you're really cranking it, you can really get a fairly significant elevation in your partial pressure. Where instead of talking, a PaO2 in the hundreds, it's not unreasonable that you're saturating their plasma or their tissues enough with, somewhere in the 500, 600, 700 range. That'll really buy you a lot of physiological reserve.
That's great. Somebody actually had a question on that too.
Yeah, let's check it out. At any point, are you obtaining an ABG? I don't. So I'm going to switch gears, and then I'm going to kick it to you, right? Yeah. So when I was at Michigan, one of the things we did is we did the chest thoracic society recommendations for the management of acute exacerbations of COPD. And what you find is that a ABG and a VBG, aside from the PO2, thank you, Sarah. They are very, very closely correlated. They're off by like 0.05 maximum on the acidosis. So to me, this is not purely a oxygenation problem. Right. I don't find that to be the problem. And what I'll do is I'll correlate the pulse ox with what I'm seeing on the VBG. I don't see the need to go get an ABG. I do find a whole lot of value in end-tidal. The literature would support that. Great product, really increases safety, both in confirmation of the success of your procedure, but also in their physiology around it. But over to you.
Yeah, so I've always said that if I could create one test, I have a couple of these things I plot in my mind. One test that would be the best test for me as an ear doctor. You have these like really sick patients, and I know that you guys deal a lot on the floors in the critical care units with them. you have these people and there's going to be an optimal time to intubate them. And you're not sure when you're going to have to intubate them, but you think that you probably will. You get them, their CO2 is 70 some, and you think that they are probably just going to continue getting worse and worse. You can kind of see that on the end tidal CO2. You can watch the pleth, but it doesn't really give you like an actual like physiologic of what is their whole body doing for CO2. So I think that there's some value in potentially like, this is again, non-traumatic patients. We kind of switched gears a little bit. Keeping an eye on the CO2 from that end, and maybe getting VBGs and see how somebody's doing. You could extrapolate that to the trauma patient just to see like, okay, their mental status is getting worse, their chest rise is getting worse, they're retaining. So I do think that there is value in watching CO2s to decide like when to take somebody's airway. But for me, I'm almost never doing ABGs.
Yeah, I really, really stray away. Like I'm now reserving my ABGs for my crypto pneumonias where I'm really worried about an A gradient from, what else?
I don't know, but
barotrauma.
I do think that there will be some future that AI will have your CO2s and like not in titles, like your actual like VBG, like some continuous like CO2 monitoring, and then say like this patient is getting worse and worse. It is time to intubate that patient.
Yeah.
I think in like 10 years that will be a thing. Yeah. And I'm sure that somebody's already doing that, but like I would love to have access to that right now, because to me the CO2 is really the decision a lot of times of like how is the patient doing clinically.
Yeah. Sarah, did you have a question? All right. Don't want to put you on the spot there. All right. Look, bottom line, first topic. Let's put a bow in this. It's been a half an hour. I don't think the DSI is just slow RSI. I think this is a bit of more finessed and nuanced opinion than the ATLS guys are trying to do with their rapidity of administration versus rapidity of procedure.
Yeah.
I think really this is set the stage for a safe, controlled intubation. I also think that, when you take the airway, you take the airway. You got to be careful about taking the airway, but when you need to do it, do it. The idea of I'm not going to take the airway until I get to the OR just in case, I think is also a little too pedantic, a little too rigid. Mm-hmm. And this is a nuanced conversation about what that physiology is doing at any given time.
Yeah, I mean, physiologically, it's absolutely the most dangerous thing that we do in the ER. Yeah. So I think it needs done thoughtfully and in a slowed manner.
Yeah. So, ATLS says, hey, recent literature, the importance of adequate resuscitation, right? So this is a little bit of a different conversation than purely talking about RSI versus DSI. But what this does really tell you is, hey, look, and especially in the trauma patient, because again, this is a controversy in trauma lecture. In the trauma patient, make sure the patient's got adequate volume resuscitation. Let's do that. And maybe recognize that if you paralyze skeletal muscle and you relax everything, they're going to lose some SVR, right? You give them some patholysis of a bunch of analgesia or sedation, they're going to lose SVR. They're perishocky anyways. Mm-hmm. They're probably acidotic. They're probably going to lose a little inotropy as well. Yep. You're adding some preload, so you're going to go ahead and drop that venous return in a hypovolemic patient. Maybe the answer is hold off, temporize, really hammer that preoxygenation, and while you're doing it, let's get some blood on board and fill the tank.
Yeah, exactly.
So yeah, hopefully this kind of helps. I did use this vasopressor line earlier today in ATLS as I was describing it to the residents. Vasopressor use in ATLS is not contraindicated. We'll talk about that.
Oh yeah, we've got lots of talk on that too. So
it is not your first line agent. Hemorrhagic shock is your first line problem in trauma until proven otherwise. Mm-hmm. So hemorrhagic shock, treat like hemorrhagic shock. Don't treat like distributive shock. Yep. All right. So to that end, we've been talking for half an hour. We have hit our first topic, and we're gonna give it a hot second here and transition over. What we're gonna do is just kind of structure for everybody. This can be a very long talk. We really don't want to soak up all 2 hours of your night if we can help it. But we've got, topic breaks between each, and after blood transfusions, we're gonna take a moment, okay?
And everybody, feel free to jump in. We love hearing voices. So if you guys want to ask any questions, we are not insulted if you jump in with a question.
Yes, please.
So, Brendan and I can banter all day. So
Yes.
yeah, we won't, I promise. But
You should hear the residents groan. It's pretty funny. They're like, oh, you two are signing out to each other. Ah.
Yeah.
All right. So let's talk about blood transfusion. All right. This is a hot topic near and dear to my heart. I was okay at blood transfusion as a resident. And then kind of later in my career, I think third or fourth deployment in, you give a whole bunch of blood, you've activated a walking blood bank once or twice, and all of a sudden you realize this really matters. And blood is such a tricky management problem from a policy thing. If you've ever run a blood program, there's no greater way to run afoul of the FDA than running a blood program. Look, history here. Partly because I'm a nerd, partly because, this is kind of critically important here. 1628, we're talking about a process that's been around for a very long time. Not a whole lot of development here until the early 1900s because, we're still trying to figure out that maybe milk is not the same as blood. We're trying to figure out that saline and milk are not the same. Like there's a lot of ongoing science here. But all this was really enabled in 1914 with the advent of sodium citrate as a long-term anticoagulant. So you can actually enable cold storage, right? Prior to that, I mean, this is like, hey, there was experiments about if you sew your vein to my artery, like, I don't know how you're titrating that venous load. Like, okay. Quite a bit of development, right? But as with most of the awesome horrors in our society, warfare does a great job of telling you what we do wrong. And, humans have been treating each other poorly for 25,000 years. I don't think that's going to stop. But the Red Cross really stepped up during World War II. Pearl Harbor really started helping people understand the benefits of volume resuscitation and colloid resuscitation for hemorrhagic shock. I don't think they got it right, but what happens? 47, we figured out maybe there's bad things that can happen in terms of the stuff we put in our blood anyways. So let's take a look, right? But then, and this is Korea, then Vietnam, ton of blood, ton of drug use, increased a ton of infectious diseases, which ironically was part of the big thing that spurred the fractionation movement, because with fractionation led to increased profit because you could sell multiple units from the same collection, but also it led to increased safety because it really forced laboratory manipulation on the blood. And a lot of that was driven by the fact that you got to be really careful with transmissible disease. So Vietnam really changed the paradigm. I don't know if it was necessary for the better, but it did. And then, Iraq and Afghanistan changed the paradigm again. So in the first 10 years of the war, we saw almost 5,000 casualties. And my brothers over in the Ranger Battalion did a really excellent review. And in 2001, the Joint Trauma Service was stuff. Like, it was really rapidly identified that we needed to collect this data. And what we found is that of our kind of breakout people who are casualties and survivability, is that you had potential survivability. And a lot of that potentially survivable people were hemorrhage, right? And that really, very few other things were deemed to be potentially survivable that were non-hemorrhagic shock. And this slide came out in, oh Lord, it was a Joint Forces Corps. I'm trying to remember. This was a non-medical presentation. Medical telling the line, i.e. the decision makers, the war fighters, we have a problem. We're losing, and there are 1,000 people who are not home who might have potentially been home. And boy, did that get people's attentions. And then Kelly, Holcomb, et cetera, they evaluated and really drilled down and tried to figure out early in the war what these potentially preventable deaths happened from, whether it was an airway problem, whether it was a CNS problem, whether it was a hemorrhage problem. Really, by and large, hemorrhage was the problem, right? So we've identified a problem. Ron Bellamy was a great dude. Ron was, he's kind of one of those guys who did everything. He was a SOCOM surgeon. He was really well published. Bob Mabry was another SOCOM surgeon. And Bob was, he's actually, I just saw him at some last week, old Green Beret, old Ranger, and then went to medical school. And again, he then took it back to the line and said, hey, look, guys, if you look at what Ron's looking at here, you see all these surgically correctable. We published a bunch of different things, and we told him, hey, here's the problem. So now this is the epidemiology of let's identify a problem. So let's go searching for the solution, all right? And that led to this and spurred a whole series of why are we not getting blood? Because at this point, it's not like we don't have blood. We know blood. We had identified TCCC and identified that ATLS was not cutting the muster, and that was back in '96. We needed a more formalized program, so the Committee on Tactical Combat Casualty Care was stood up. And really, it was this first 10 years of the war that said fractionated therapy is not as good. It doesn't work. Let's try whole blood. To me, it kind of, this, I was a young doc at this time, so this is, I was too young to really know this, but this was kind of that well, duh moment, right? You don't bleed just your red cells, just your plasma today. Yeah. So it had face validity. It had good pretest probability. And then a whole series of studies came and supported as whole blood as being the right component therapy. Here, no, there, click. Okay. So in 2014, all of that research led to this one little line. In descending order of preference are whole blood, period, full stop, done. All of you who've been practicing prior to that, remember is it 4 to 2 to 1? Is it 1 to 2 to 1? Is it 2 to 2 to 1? Is it 1 to 1 to 1? And they said, yes, 1 to 1 to 1, not terrible. But at the end of the day, put back in what came out. That one little line changed everything across the DoD. It was astonishing how policy is written and derived. And now what you're seeing is this is making its way into the US network. Right now, UVA has switched to whole blood resuscitation, and our EMS networks in the area are kind of in the process. So this is truly a sea change.
So as a person that deals with blood products, UVA, how does it change the storage of, like how long can it be stored? Because my understanding is, I consider platelets the ground beef of blood products, right? Because they come from multiple individuals, they can't be stored at, cooler temperatures, and they have a short shelf life.
They really do.
Right. So it really is like the ground beef products of blood products. How long can like whole blood be stored? Does it change at all?
Oh, it's 42. It's awesome. And, we'll talk about that a little longer, a little later too. But, a lot of that is enabled by advanced anticoagulants. So we've identified the products that go in there to support the blood. But at the same time, if you're not pooling like you are with platelets and you're using the platelets that are in there, you're great.
Yeah.
Platelets deteriorate. It happens, right? Their function is not quite as good. You'll see a bit of a decrement in the curve somewhere around the 14-day mark. But really, platelet function is still preserved. We do make an effort to give cryo and calcium because, of course, those aren't. But give whole blood, you lose the platelets, keep it 42 days. Now, most of what's happening with most of the labs is they're taking it back and they're fractionating it kind of in the 25, 30-day mark, so that they can turn it into products that we can then use for dedicated transfusion or routine transfusion, like in your outpatients, that kind of thing. So, yeah.
So good from a resource perspective, too.
Yeah. Michelle, does that answer your question, too?
Oh, yeah.
Yeah. All right. And then Sally Ann, how can trauma assisted community?
Yeah, read the question for folks.
Yeah. So I'm going to read this out for everybody. Good evening, Doctors Burns and Kearns. How can trauma systems and community hospitals practically overcome the logistical and regulatory hurdles of stocking pre-hospital blood without increasing product wastage? So look, love the question, right? And what I'm trying to do with my EMS chiefs is host a forum where we're specifically dedicated to these, because here's the honest answer, right? This is CME talk. Half of what we're doing is describing for you the science, because CME often, if we're docs, we get cerebral, we get science, right? Science is only so good as the logistics that support it.
Yep.
So we've got a couple ways to do this. And what we see is you have large depot centers like Inova in Northern Virginia. Inova's blood bank actually has two separate components. And one of their components is to serve as a regional depot for programs just like this, where you are ordering blood from them, they're coming supplying, they're coming picking up, so that they can get it back for recycling and they don't have wastage. And UVA right now is not, because we don't have the bandwidth for that. And Inova, frankly, their blood bank component is larger. I would argue that if you have your blood bank on the phone, what we've seen as kind of a good thing is, especially when you have kind of 1, 2, 3, 6 EMS systems, it gets as scaling gets hard, because scaling on all logistics gets hard. Put a blood fridge. They're actually Dometic fridges show excellent Dometic temperature control. And what I tend to do is I'll put them in the supervisor vehicle of an EMS rig, as opposed to on the individual rigs. The medics can call for a soup vehicle to come in when there's a need for blood. And that way it kind of acts as a hub and spoke model within an EMS network. And then that blood stays temp controlled, logged, all the QC requirements of a blood program. And it does so for, it does so as long as really you need to. And really we tend to set ourselves about a 21-day cycle, because we find that 21 days is kind of that sweet spot where you can cycle it back out, you can fractionate it, you can get it back to the blood bank, and then they can distro it to sites like ONC or infusion centers that are doing routine transfusions. So we find that 21-day mark to be a good compromise. It's not perfect, but again, if you haven't used it, now you are recycling it, you're not wasting it, and it ends up still being a very kind of resource conservation mindset kind of activity. If your blood bank can support that in the local area, in my mind, that is the community level, system level engagement that really is the true function of a community hospital. So, I don't know if that matches your profile. I'm happy to come up on the net, Dr. McIntosh, and talk to us. What do you think?
So no drone companies yet.
Actually, you say that, but one of the grants we were working on up at the University of Michigan was Toyota was manufacturing drones, Toyota the motor car company, for use in large mass scale gatherings like concerts, festivals, etc., where you'd geotag, you'd have camera information, you'd send out your roving teams, and you could literally drop either an ALS pack or a blood pack. The fridge, we do a cooler system, a golden hour box cooler system, and that cooler is about yay by yay by yay. So, fits 2 units of whole blood, which are slightly plumper than normal ones. But, I know it's hard to scale on a screen. I'm holding my hands about 10 inches or so apart, right? These things weigh 2-3 pounds, so we're not talking a lot of mass. So they can be easily carried by most commercial small drones. and easily identified and dropped. So, drones are
In the
coming.
future, we joke about with like ProFab and DigiFab in the
Ooh.
future. Yeah. So stay tuned. Yeah. Just a few more years. So.
They are doing this in Ukraine. Cool. I appreciate it, Dr. McIntosh. They are doing this in Ukraine. They're dropping blood on the front lines because you can't do anything in Ukraine without a drone dropping on your head, either in this case positively.
Yeah, as you say, good or bad. Yeah.
Most of the time, not very
Yeah,
positive.
usually I don't want to see a drone. Yeah.
No. It's made me a little paranoid these days.
Yeah.
Okay. Back to this. COTC went all in, and the DoD said, look, this is what we're doing. Whole blood is now a theater requirement. Fast forward to this year, that was 16. This is 26. So a decade it took for ATLS to finally catch up. And they did so in a couple ways, right? So blood is great. What's better than blood is not losing blood. And if you really look at the algorithm, X and M are functionally the same thing, right? So this is actually the slide from 2016 or so when the TCCC was changed. This is today's slide. Airway, breathing or respiration, circulation, disability, and hypothermia and heat and environment. Like it all kind of meshes. But at the end of the day, ATLS is finally caught up. Again, they slip it way down, right? Red cells and other, and their recommendations are much softer than the DoD, but they say including whole blood. So ideal resuscitated fluids for hemorrhagic shock. End stop, right? People are buying off on the science. So kind of getting back to what you were talking about, Dr. McIntosh, I started at UVA in July of 24. So it's been 2 years, almost even. That fall, I had identified that we weren't using whole blood. That to me was kind of personal pet peeve. I've written the policy that made this a training standard for the Marine Corps back a couple of years ago. And so, thankfully, we had a new trauma director and we had a really fantastic blood bank director. And so I walked into just the perfect milieu and everybody was pretty happy. Now, the downside, supply chain was our biggest hurdle, right? We are not as high of a volume blood center as others. So it happens. So,
For receiving it or
for
donations?
use.
Yeah,
for
okay.
use, yeah. Kind of a throughput burn rate. That's the best way to put it.
Okay.
So I had to write a protocol. There were inherent compromises in this protocol. I would argue that there is no reason to really put this lower cutoff, but those of you who've served on hospital committees will immediately appreciate what I'm saying right between the lines as I kind of wink and nod as to why protocols happen and change, right? We were really worried about our supply chain, and so we were not going to transfuse whole blood and burn our limited supply for futility. For no, patient autonomy is still a thing, so no religious objection or other objection. And then, we're not doing this willy-nilly. We're not just giving whole blood in our limited supplies for routine care. The idea was hemorrhagic shock. And so we kind of broke off our algorithms. And then, we had a limited cut in our fridge at the university down in the ER that is right across from our trauma bays. And we said after that, we're going back to the old, 1-to-1-to-1 because that's what we got. And we'll go to a massive transfusion protocol because, again, a whole blood unit is 500 and some, right? So a bigger unit. So by the time you've given 2 full liters, you're approaching, you should really think about massive transfusion. Where are we going with this ship and why have we plugged holes anyways? I did want to make this slide, right? Kind of as we're talking to our docs, this is directly from our education product that I presented to our department. And it really was a why. What are you ordering and why, right? So kind of in order of the volume of stuff that you're doing, right? So if I'm just doing routine care, I'm just going to order routine stuff. That really primarily means cross-match blood. This is for people who need blood, maybe during their ER stay. Again, order it normally. Whole blood. Whole blood, was we had this fast blood, which is you can get regular component blood down quickly. This was the old protocol. It still was existent, right? But symptomatic, you need it pretty quick. We kind of made a compromise and left this in. To this day, that fast blood still does persist in our protocol. I don't think it's going to do so forever. At least I hope not, if I had it my way. Whole blood, and again, this is a supply chain problem. Hemorrhagic shock, use whole blood. And we have an additional 2 units in our lab that can get called down. So we've got minimum 6 on hand at any time. And then massive transfusion despite whole blood. When it doesn't work, you go to more. A couple caveats. It's a little more volume, right? Risk of fluid overload is a little higher, but it works better, and it does. And it's not anecdotal; like the evidence says it. That's product. In our peds patients, ironically, so we pull the unit, we give the appropriate cc's per kilo, and we're still following a 10 per kilo, and we're expecting a certain degree of waste. But that is not technically waste because it's counted as a dose adjustment per blood bank. I don't argue, and I don't want to hold them. I don't want to bite the hand that's feeding me, frankly. But part of this was kind of our own critical appraisal of how time critical it is, and that refers to the previous slide. And then, give some thought as to what your physiologic mechanism is. All right. This is always a question. Our whole blood supply is O or H positive. By far more common than negative, but it's still a consideration, right? And is anti-deformation a reasonable risk to assume? When I looked this up, actually, it's shocking the amount of research on this. On how much alloimmunization actually happens. It's really only about 6%. It's not that impressive. The maximum upper limit in the literature is 30%. So it's not as high as it happens, and that's with known incompatibility. To that end, we say, look, risk benefit, right? So we kept that decision criteria at the level of the attending. What was interesting on that, though, is when you put in the stuff I didn't put on this slide, and you looked at the social research that said, what do women prefer? Overwhelming, they were like, the functional equivalent of damn the torpedoes, just give the blood.
Yeah.
So who am I to say no? Like we do community focus groups, we do social research, and it says I want the blood. Well, okay, cool. And frankly, since it's a future problem and it's a problem that you have 72 hours to give ROGAM, and ROGAM is now kind of being called into doubt as its utility anyways, right?
Yeah, it's a whole other discussion.
Whole other
really cut back on ROGAM use.
Yeah, totally. So our answer is you gotta be pretty concerned, I think, to say no in this case. Would be my take on the matter. All right. So I put this in here really for 2 reasons. One, because this is where we slipped the bit into the bottom and said we can recycle it. 2, you'll hear a lot of people remember the diamond of death, or the lethal triad. It really truly is the diamond of death. And whole blood is still a citrate-based anticoagulant, which chelates that calcium. So please give the calcium. When we do autologous blood training and we do transfusions in special forces, guys will take their blood out, put it in a bag, and then get their own blood back. Right, so I'm not worried about the transfusion reaction, but they still do get a little chelation, and we have a measurable drop in blood calcium stores. Tom's fixes a lot; it's amazing.
treats a lot of things, including several talks things too. So, yeah.
Amen.
Yeah.
All right. So that concludes my blood question or my blood process. We're open to any questions, and then we've been talking for nearly an hour. My suggestion is we take a little minute break. Dr. Moore, if you're good with that. All right. Hearing
Sure. I think that's, yeah, give them a few minutes to stretch their legs and walk around. As they say on TV, no clicking, no changing channels. We know everybody that's on the call, so we want you to stay with us. Let me ask you something that may or may not be relevant. As an intern at Johns Hopkins an eon ago, I was taught nasotracheal intubations. Is that standing? I'm not taking care of acutely ill patients for a number of years. Does that still have a role in urgent resuscitation, or when is that now recommended to be used?
Probably depends where you're practicing. A lot of these new places have these really high tech kind of fiber optic type things that really you don't have to, tell them to take a breath and wait for it. So a lot of places will have the technology that you can just basically put in a tube and a little camera in the nose and kind of bypass that. We did it where I did residency at Allegheny General Hospital because we did not have that technology. That's where the pit was filmed, if that gives you some perspective of what I trained in. But I think it probably depends. There's definitely community shops that I would do it in if I needed to, just because I would probably feel more comfortable doing that than actually using some of the little cameras. But what are your thoughts?
I use them all. I also trained on it. I like it for what it is. I like it for a lot of different things, especially when you're trying to avoid oral manipulation, like your angiodemics.
Yep. That's the classic one that I think about it too. Yeah.
Yeah, it really is. I would argue that I have used it increasingly less frequently. And a lot of that really is better facility with awake fiber optic intubation, bronchoscopy, and bronchoscopic intubation.
Yep.
Your direct video laryngoscopy has helped as well. But it is a technically more difficult, trickier space to
Absolutely.
get to. Your kind of old mentality where it was stick the tube in and use the McGills to manipulate.
Yep.
Works great, but still not objectively as secure as using a bronchoscope or an endoscope.
Yep.
There's a question that just popped up.
Yeah, Brandon Crawford asked, is there a specific ratio of calcium gluconate to units of whole blood? Is it a simple 1-to-1? Yeah, I think that's not unreasonable. Usually I wait until the second unit and I'm giving 2 grams at a time of gluconate usually, and I give gluconate just because it is generally more readily available. If I'm drilling somebody's bones, chloride is a wonderful product, and I'm still a huge fan. But that functionally amounts to a 1-to-1 is pretty reasonable. And that is consistent with our protocol, both in the DoD as well as at UVA.
Any other questions before we let them start again? I would just make one observation. And watching on TV, the TV series The Pit, they're always calling for whole blood.
Yes.
They call, Noah Wiley calls for the whole blood when they hit the door, and then they're going to the unit with 3 or 4 more units of whole blood, negative whole blood. So
yeah, I wish I had a supply.
The Pit thinks it's okay. So
yeah, I know they actually had fairly integrated conversations with the physicians at AGH too. So it's pretty neat. Yeah.
And their technical advisor is Mel Kiper, who's a UCLA doc.
Yeah.
And he's not far away from a few of my colleagues in Southern California.
Good. Yeah, it's a great show. Okay, let's get maybe move on, and we'll get folks going here. Thank y'all.
All right.
Great.
You want to call it back at 10 after, sir? Or?
Yeah, I guess I think we've still got everybody there. Let's see.
What do you just want to do?
We've got everybody there. At least it's still locked on.
Yeah, it's your show. Hey, tell you what, Can we get a show of hands for who wants to immediately press on? That is not a lot. Show of hands for who needs a 5-minute break.
Their own break, I guess.
All right. Well, how about we'll come back in a few minutes and then we'll get going. So
Sounds good.
Yeah, so for everyone else, hang on a second. We're taking a little break. We need to study how to do it. Maybe someday we can have a musical interlude at this point or something. We should probably go ahead and get started again.
Perfect bio break. Thank you, sir. All right, we still got a good screen?
Yes.
Very good, sir. Okie dokie. So let's talk about thoracostomy, right? I think this was a topic you guys had identified and we kind of talked about as well. You know, the question is, you're sticking a tube in, you're doing a procedure to violate the thoracic space, you know, does it matter? ATLS's 10th edition kind of really hedged a lot. They were talking about the problems with needle decompression. That's kind of based on the old research that showed that maybe the needles don't get all the way through when taking the anterior approach, right? So they talked about doing over the needle in the 5th interspace and moved it down here, which had been the DoD standard by that time for a couple of years. And so, you know, they were still on this 28 to 32, which is large bore chest tube, right? Well, the 11th edition says, oh, okay, axillary, yep, sure enough, that's the bag, right? Included a skill station that now mandatorily includes finger and tube thoracostomy. I will tell you that all of my EMS groups, it used to be that you could not puncture the chest with a needle until the patient was dead. Once they lost vitals, you could do that as a rescue device. I'm not a big fan of waiting for death. If we could,
I like to prevent it. Yeah,
you know, it just seems,
I like good outcomes.
Yeah, seems incompatible with,
Yeah,
hey, do me a favor, circle the drain just a little more here. Right. So, ATLS likes it. So anyways, So I went hunting for evidence, right? And I kind of did my own lit review here as to what we're looking at. One of the things I found, and I'm going to propose this because what I find practically, especially from having worked in a lot of 5 to 30 bed hospitals that are very small critical access hospitals, these are not high frequency procedures and you forget it. So I don't know, I have no vested interest in this website, but I thought that they did a really good job as I observed them in kind of how they documented how to do a procedure.
Mhm.
And frankly, it gives your patients a little more confidence than YouTubing something. So I offer this to you as an option if you're not a Robertson Hedges guy. And, I'm a little old school in Robertson.
I am too. Yeah. But the electronic edition.
Yeah, it's a new
It's
day.
too heavy
new
to
day
carry
and age.
around. Yeah.
So that still begs the question, though, what's the literature say, right? Turns out that if you look at open access, you look at that surgery at the literature, and hey, trauma and acute care says, oh, this is a great review article.
Mhm.
And she looked at all the literature, and sure enough, it says, this works. So the summary here was that a placement of a pigtail at bedside. They also talked about pericardial windows in kind of the general concept of minimally invasive thoracic trauma. But they said there are options available in the management of chest trauma. They talked about a bit of a learning curve, but they said, look, safety, efficacy appear to be similar to large bore tubes. What they did find is that there tends to be a duration of less than a total day difference in favor of small bore tubes. Like they come out earlier for good reason, not because they fall out, but because they actually work out. Their impression kind of subjectively is that the quality of that evidence that supported that recommendation wasn't great. I get it, but it did seem to be they did identify that the biggest hesitance to switching from large bore to small bore tubes was simply provider reticence, right? People aren't comfortable with change. It happens. So moving on though. Next, so the Eastern Association for the Surgery of Trauma actually changed their practice management guideline. As recently as 2021, the Professional Society's clinical practice guideline said for stable, go pigtail, even including hemothorax. So your risk of incomplete drainage, your risk of empyema, your risk of loculation, your risk of clotting, which is the kind of big one that everybody talks about, is not significant enough to stay away. So let's do these. They were a little conditional. They had a whole algorithm up, and we'll show you Western Trauma Association. And for those of you who don't know, here's their website. They go down and they list all of their various algorithms. I've blown this up because clearly you couldn't see it, but basically they said, and the key differentiator here is stable, unstable, right? So for stable, mirroring east, they said do small bore tubes, works just fine. Unstable, they're saying finger thora.
Yeah, and that totally checks out with, I think, everything that we practice clinically.
Yeah.
I mean, if you've got somebody, you've got time, right?
Yeah.
And so if the pigtail fails, you've got some time to reconsider that and decide if you need, wide bore is kind of how I think about it too.
That's kind of how I think about it, right? It's you haven't broken or bought anything at this juncture.
Yeah. Yeah, I've saved the patient a lot of pain.
Our next big thing here in 23, so about 2 years after that earlier one, this is a small meta-analysis. I apologize. I'm not trying to make you guys dizzy there. Only 7 studies met their inclusion criteria, but they were pretty overly, for a surgical literature, this is pretty overwhelmingly positive. 7 studies met it. Higher initial outcome in a smaller tube versus a big tube. And that's it's a pretty significant volume difference there at 115 cc's. Chest tubes, large chest tubes had a higher risk of VATS, which is not an insignificant problem. I don't want you cleaning out my thoracic cavity if you don't need to. So, this meta-analysis post-dated those recommendations and seems to continue the trend. So, I'm an ER doc. I rarely live in isolation, especially in the ivory tower. But from my perspective, this is the way to go. From your clinical scenario, I would argue that this is a great way to go.
I personally would prefer a pigtail over a wide bore if I was stable. I think the big question that I would have to dig into the data on this a little bit more, is there a downside to having blood? If for some reason, if there was like you're saying, it gets out the same speed, it's just as fast as emptying the chest. But if for some reason it did, is there a downside to like keeping a little extra blood in that chest longer? Adhesions, things like that.
Your calcific hematomas, your adhesions, your empyemas in a blood-rich environment go up. They didn't find them significant enough in this review that they bothered to mention it. So I don't know that it's really a big deal in favor of one way or the other. And I think, I don't like research that's always just non-inferiority studies. I couldn't make something show a benefit, so I had to publish something anyways. This, I love the non-inferiority. And in fact, mild superiority in certain circumstances. Yeah,
that's interesting. I think most people would agree that this is probably the most painful procedure that you can undergo in the emergency department.
Yeah.
Is what most people will say. I personally, luckily, never had to have a chest tube, but I know many physicians that have, and the way that they describe it is pretty bad. So.
Yeah, I have let to date 24 people put IOs in me, and I've let 36 people intubate me. And I'm not going to pretend that any of those were terribly pleasant. IOs are not really they're not the thing anybody fear, frankly. I don't have my leg hair up on screen, but my legs are relatively hairy. And for reference, the wrapping of the hair around the drill actually hurts more than the needle in the bone.
You're going to get arthritis. I'm sure that's an independent risk factor for arthritis, is having med students and residents.
I don't know if metaphysis is really a thing, but I've already got arthritis. but I would argue, this is objectively described as a more, or I guess subjectively described as a more painful procedure, and I would prefer the smaller.
Yeah, no, absolutely.
It's easier to anesthetize process.
Yeah, significantly easier.
All right. So on that note, though, quick short topic. I felt the evidence was relatively conclusive there. There wasn't a whole lot that I needed to bore you guys or kill you. I think it's a Seldinger thing. For those of you who are hospitalists and, there may not be a traumatologist always on call, it is a more natural procedure, I would argue, for you in the days of central lines. And so I would suggest that it's a great option. I'd give it a shot.
Yeah. And I think just getting comfortable with pigtails, if you guys haven't done them before, like you said, it's a Seldinger technique. You just have to be aware of your landmarks and not going too deep is probably the biggest thing that I talk to the residents about.
Okay.
All right, so we're going to switch gears. This is the last topic. And if my voice sounds familiar, it is because I worked as a fellow at the Blue Ridge Poison Center for 2 years. Graduated 2 years ago, and now one of the faculty members. So I might have talked to a lot of you guys in the wee hours of the morning, 2 a.m., talking about Tylenol or any kind of overdoses. So it's always nice to kind of see you guys on a different type of sphere. But like I said, toxicologist by training. So I'm going to get really nerdy with the vasopressors. What I did today, so Dr. Byrne and I taught ATLS, and we had the manuals pulled up. I did a big Control F for vasopressors, norepinephrine, epinephrine. There is hardly anything in that ATLS 11th edition on those things. And really, if I was going to make a slide on how ATLS feels about vasopressors, I joked with Dr. Byrne that it would just be a series of garden hedges, because they like to just kind of make these hedgy statements about how to manage them. All right, so like any good EM lecture, we're going to start off with a case. This is a 28-year-old man who was brought to the trauma bay after a high-speed rollover MVC. For those of you guys who do not have to deal with traumas, a lot of times people will come in and you'll get a GCS of, 6. Usually the mantra is less than 8 intubate, right? So this is not a good GCS. You want it to be like 14, 15. His blood pressure is 74/42, heart rate 128, and satine 93% on a non-rebreather. So just kind of thinking about these vital signs, as a physician, I am not happy with these. A lot of times I'll tolerate some tachycardia. When people get brought in as traumas, they're in pain, they're anxious, and they're nervous. So, maybe a little bit of tachycardia is okay, but that blood pressure should absolutely terrify you. And that GCS should definitely make you nervous. So really bad kind of clinical picture just based on those vital signs. You get some findings back. You do a FAST and you look at his right upper quadrant. And for those of you familiar with FAST, you guys will recognize this immediately. But that's the little liver edge hanging out in a bunch of free fluid, right? That black stuff is all blood, so not good. And there's the kidney. So pretty classic positive FAST. You get an x-ray of his pelvis. And really, if you're kind of looking at the center of his pelvis, there shouldn't be that giant gap in the middle. That is called an open book pelvis fracture and can be the source of hemorrhagic shock, right? And of course, you're going to get a head CT and you get an ICH, so lots of bleeding, lots of midline shift, and you're worried that this guy is going to herniate here soon. Next slide. So like Dr. Byrne mentioned, you're going to activate massive transfusion protocol. He gets 4 units of whole blood. He gets TXA, and you put a pelvic binder on his hips. So despite all of these interventions, he is still hypotensive. He is 78/46. So you identify persistent hemorrhagic shock. Not good. Got the quickie for me.
Gotcha.
All right. So we're going to do a quick pause right here and really just kind of think about, what's going to happen. This guy is going to get worse whether you want him to or not. So let's just take a quick picture of kind of where we're standing. He is in hemorrhagic shock despite 4 units of whole blood. He has a concurrent severe TBI with midline shift. And he's got something that's bleeding because, right, his blood pressure has not responded to that blood. So their blood is going somewhere. As the ER doctor, the thing I probably like the least is he has a GCS of 6, and I have not controlled his airway yet. So he is aspirating potentially some blood, secretions, you name it, right? So before we move on, mentally, you guys don't need to click in for this, but just commit to some form of treatment strategy of like what you would do if you were in the trauma bay taking care of this patient. Would you give him more blood products? Would you throw him on some norepi? Would you start vasopressin? Would you go ahead and just intubate him or go straight to the OR? Right? So kind of think about what you would do. A lot of us who have done ATLS, and I don't know if you ever had this thought in your head, were basically told that vasopressors were contraindicated in hemorrhagic shock.
Mm-hmm.
Was there any point in your career that you were like, I can't give vasopressors?
Oh, absolutely. Yeah.
Yeah. And I think that really kind of stuck with a lot of us. And the goal of the next 10 minutes is really just to kind of get you guys to think that that's not necessarily the case. And that was never the goal of ATLS. Right. So we've all been in this position where, you have this patient in shock, you have a TBI, and you have to do something. And you're like, the only thing I have on hand are vasopressors. I was told not to use them. Not doing something feels wrong. So you're like, I got to do something. So that's the goal of kind of our discussion here. Click for me. Thanks. All right. So like I said, most of us were taught that you should not use vasopressors in shock. That is not what ATLS says, actually. And I don't know if they've ever actually said that.
So they did in the 11th. If you go way down, it's like tucked in the compendium.
Tucked hidden in there? Okay. They're pretty explicit about what things are okay to use vasopressors on. Dr. Byrne mentioned briefly RSI-associated hypotension. That is an absolute. Give them some, whatever you want to give them. Whether it be epinephrine, phenylephrine, whatever your pharmacologists have on hand, you can give them just a whiff of to get that, through that 10 minutes of just hypotension, right? Because they're really going to, like you said, drop their sympathetics. And that's probably the most dangerous time for that patient is when you give them medications and you switch them over to a positive pressure ventilation, right? ATLS completely fine with you giving them some vasopressors with that. Neurogenic shock, right? I think everybody knows that if a patient injures their spinal cord and drops or sympathetics, you got to give something, whether like Levophed or a little bit of epi, to try to get some perfusion to their spinal cord, right? Lastly, they do say that if somebody is persistently hypotensive despite resuscitation, and they don't really identify like what is the resuscitation. They don't say, 4 units, 6 units. They don't give that, but they do put in there that it is okay, right? So there's several very specific things that they say it is okay to give pressors for. I think that the message kind of got lost in the sauce because, everything that you said initially is the main takeaway. Vasopressors are not a substitute for giving blood products. If Dr. Byrne falls out, on his driveway and starts bleeding, I don't think he wants me to just give him a bunch of norepinephrine. You want some blood, right?
Yeah.
So you want to give him some blood, right?
Things.
Yeah, you want all those blood products. The biggest thing is it's not a substitute for hemorrhage control. And that's probably, I think, for me, the biggest takeaway from the new ATLS is like really like putting that X before the ABCDs, just for people to mentally be aware of like control the bleeding, quit losing blood, and then you can get the situation under control.
Yeah.
So any questions on that so far? Feel free to kind of jump in.
And Dr. Anea, we do see your excellent choice of going straight to the OR. That's not,
Yeah.
I love it.
Yeah. Unfortunately, sometimes there's a little bit of a lag, right? So, why were we taught this? This wasn't just like created by some trauma surgeon who had a vengeance against Levophed, right? There was data that actually supported that potentially pressors were bad. The issue wasn't, with the actual Levophed, it was with the studies. So kind of looking at like older studies, there wasn't just one, there were multiple studies and quite a few of them that actually showed that early vasopressor use increased mortality, right? So multiple studies that show that increased mortality, increased complications, worse surgical outcomes, right? And so why did all this data support that?
I mean, I love not being the man in the arena. It's really hard to design a good study.
Mm-hmm.
And, I think it's pretty easy to see a study that looks at the secondary endpoint being, when did I give a vasopressor?
Yeah.
And failing to look at the fact, well, I gave the vasopressor because dude's dying and
Exactly,
I gotta
yeah.
do something.
100%. That was the biggest problem, was that, you were giving the sickest patients that you could not resuscitate vasopressors. And it wasn't necessarily causality, but it was more of, the people that were getting vasopressors were just really sick patients. So we gave it a couple years, a couple of decades, and we looked back at these studies and we realized that really it was not the vasopressors that were the problem. It was more that the sick patients that were getting them. And so to really understand this, I think we need to take just a brief kind of look at the physiology of shock. I know that there are a lot of internists on this video call right now. So I think that you guys have, great appreciation of how complex shock can be, whether it is cardiogenic shock, whether it is septic shock, any form of like distributive shock, anaphylactic shock, like you name it, it doesn't matter. I think that really we simplified like traumatic hemorrhagic shock like way more than it needed to be.
Mm-hmm.
So I think that was part of the problem too. Luckily, we have some new data that actually helps us understand traumatic hemorrhagic shock a little bit better. But to kind of think about like how we thought about shock for a while, for decades and decades and decades. I take a knife, I stab Brendan, mad at him. He starts bleeding and he gets hypotensive. As a result, like he talked about earlier, he's going to get a bunch of constriction, vasoconstriction. His SVR is going to increase, right? And his lactate is going to go through the roof, right? Because he's not perfusing a lot of organs that want perfused, right? So you have this huge sympathetic response, vasoconstricting, SVR is going up, your heart rate's going crazy, his catecholamines going through the roof, right? And so that was really the traditional view of hemorrhagic shock. And really that's not the full story with this. The idea was that if you gave somebody vasopressors that cause, a little bit of alpha constriction on top of that, it's going to worsen your perfusion, right? Makes sense if you like to think about physiology, that kind of checks out, but it's a way oversimplification of that process. Realistically, you can have 2 patients that have the complete same blood pressure, but are in different phases of shock, and they'll have different physiology, and they'll need different treatments. One patient might need blood pressors, one patient might just need more blood.
Yeah.
So any thoughts on that?
I think the nuance of ongoing resuscitation
Mhm.
is really it's a bit of an art. It's
Yeah.
a bit of a mystery, but there are endpoints and markers we can look at,
Yeah.
and there are ways to do, whether it's adjunctive studies, whether it's rush exams, so you can appreciate what someone's physiology is doing. But I think that's why we have a better modern understanding.
Yeah, no, I agree. It's, we are lucky to live and work in this area of medicine is how I like to think about it.
Amen.
So let's kind of transition to like how we understand shock now and from a trauma perspective. On the left side of the screen, early hemorrhagic shock, everything that we mentioned. Brendan gets stabbed. He has like all these sympathetic biogenic amines that are just going absolutely nuts. His norepi, his epi, everything is going crazy inside of him. His blood vessels tightening down, clamping up, and really trying to perfuse the organs that matter, brain, heart, everything like that. That is early sympathetic shock. If you move into the later phases of sympathetic shock or hemorrhagic shock, it's a little bit more of a kind of sympatho-inhibited approach. So everything that happened earlier has kind of petered out. His catecholamines have slowed down. He is sympathetically exhausted, and he just cannot maintain that SVR. His vascular hypoactivity has basically decreased, and you're going to get vasodilation and vasoplegia. So basically, those vessels that were really tight and doing a great job of clamping down can't do anything anymore. Yeah. So they are kind of just hanging out. They're big, and they're not able to really increase your SVR kind of like they were.
Yeah, it's funny. I think this is a concept really easily relatable to most of our pediatric colleagues, right? As they talk about warm and cold shock. I don't think we've done a good enough job talking about this. And it's a difficult concept to figure out in the heat of the moment when you get that patient dragged in off the street, where they are in this kind of bimodal phase. But
yeah, but I think, like you said, like the big picture is appreciating that there are multiple types of shock with hemorrhagic shock. And, for all the internists, like you guys are so great at treating septic shock. I think that the lesson to be learned is that, when we get these patients in late hemorrhagic shock, they're actually a little bit more like probably a septic shock. It's not just blood loss. They have this huge inflammatory response. As a result, the endothelium there's nitrous oxide being released. So it's more like an endothelial type of issue rather than just like a pure blood loss type of issue. And so I think that this is really like where the vasopressors come in, right? So this is kind of like a newer thing. So we're going to step back, way back. Dr. Byrne was probably taught about permissive hypotension.
Oh, yeah.
And this is the exact same idea of like, do I want to drive this blood pressure up, or am I going to let it hang out pretty low? This is probably going to be the most relevant and most important part, thinking about like vasopressors and blood pressure. So we'll jump on to the next one. All right. So, if you go way back, I don't know how many decades we're talking, like 10, 20, 30 at this point. Way back in the day, there was this idea that if you let somebody's blood pressure remain low, they would do better, right? And again, we're all like pretty smart.
Don't pop the clock.
Exactly. Yeah. We're pretty smart people. And so we can think about that. And we're like, this makes sense. We all garden, right? So we've used hoses. And if you have a lower pressure coming out of that hose, you're going to have less water coming out. Checks out. Makes sense. They're going to bleed less, right? You're going to lose less blood. You're going to pop the clot less likely. They're probably going to get less crystalloid administration because, they're losing less blood. Again, data supported this, not just a single study, but tons of randomized control trials, retrospective studies and meta-analysis supported this. So this wasn't just like some, trauma surgeon that just was like, okay, let's try this out. It's working. Let's go. Like there was legit data support this. The issue was that these studies were like hugely flawed. The biggest problem with it is that they excluded severe TBIs, traumatic brain injuries. And really the TBIs are the people that you need to have like good blood pressure.
Yeah.
That is, one setup for a poor neurologic outcome if you allow a TBI to have permissive hypotension, right? So that was the biggest issue with the studies. There were some smaller issues, their targets of like, what is permissive hypotension? What is our goal map? Really, those were out there too. Those were problems too. And also these studies predated the use of whole blood, right? So lots of issues with that too. All right. So I won't get too much into names of journal articles, but there are a couple that are kind of interesting just to think about. Really we have a whole host of pressors that we use. Really the biggest ones that I use clinically are Levophed, epinephrine.
We lost the slides.
I'm gonna give them a minute, they'll log back in.
Okay. Everybody stand by. We're having a little technical issue with the slides. The wind's not blowing the same way from Danville, I don't think. There they are.
Oh, there we go. All right.
All right,
We're back.
And we're back on. Okay, great.
Thank you, Ms. Mayo. I apologize.
Yeah, I actually came to his house because the Wi-Fi at my house is unreliable. So
Can you bring up the slides again? Or we ran out of cans, either one. There we go.
All right, good deal.
We're good.
Back to our regularly scheduled program.
Kind of back to what I was saying. We have a lot of vasopressors that we have the opportunity to use. I always tell the residents, norepinephrine, never the wrong answer. Might not be the best answer, but it's never going to be like the wrong answer, right? So kind of thinking about that, the first study really actually looked at norepinephrine for trauma patients and hemorrhagic shock. Really, this didn't show that it was better, but it didn't show that it caused harm. So it is a good starting place to kind of think about if you're using a vasopressor on a trauma patient, norepinephrine, completely reasonable. We don't need to jump into the study too much, but just, again, realize that it did not cause harm. All right, so talking about the AVERT trial, I know most of you guys probably use vasopressin, septic shock, all the different types of shock. From a trauma perspective, there is a really interesting mechanism that we'll jump into with vasopressin. But before we do that, just kind of like thinking about the big things that the AVERT shock trial showed. Lower blood product use at 48 hours, no increase in mortality with use of vasopressin, and no increase in complications. Wow. So some promising data from vasopressin. Next slide, one of these complicated kind of photo things. But really it'll demonstrate of like mechanistically why this makes sense. So why vasopressin? When you're in shock, you deplete your endogenous levels of vasopressin. When you give somebody vasopressin, it's really going to cause, if you look on that left lower side, vasoconstriction through an independent mechanism that does not use catecholamines. So fairly interesting effect there too. Really, it is not going to affect your chronotropy, right? So heart rate shouldn't go too wild with that versus if you give somebody a bunch of epi, they're going to get tachycardic and everything. And really, vaso probably has some of the best evidence in hemorrhagic shock patients. So stay tuned. It's not really first line, and ATLS is so many years away from saying that this is a first line thing, but just be aware that it might be something that is reasonable in the future.
I'm kind of liking seeing that. I'm harkening back to ACLS and when vaso was part of everything and went in. But anyways.
Yeah. So again, so kind of stay tuned, but when you think about vaso, just think about you've depleted your intrinsic vasopressin, you have this huge vasodilation picture, you're hypotensive because of that, and you give it to them and they basically can have increased tone. So that vasoplegia that we talked about initially has been restored. So again, great idea. We'll see where it moves going forward. All right, so really just, three populations of people that ATLS really kind of impresses upon the use of vasopressors. My partner is a neurocritical care physician, and so I would be slightly amiss if I didn't spend a little extra time on this. But really the people that you should absolutely care about the blood pressure are those with TBIs. So if somebody comes in and their GCS is 6, they're not mentating well, their pupils are blown, do not let their blood pressure sit low. You want that blood pressure to be high. You don't need to be 220, but don't let it sit 70 over 50. That is a neurologic devastating outcome for that patient. You can do everything else in the world to fix their hip fractures, but if their blood pressure is low and they have a TBI, they will have a bad outcome, right? So just kind of remember your cerebral perfusion pressure is really what you care about. For some of you folks that work in smaller hospitals, that might mean that you need to transfer the patient a little bit sooner to some place where they can put a device in like a bolt and actually do like ICP monitoring. So that is a very good reason to transfer a patient. And if you call the folks at UVA or any other kind of major institution, they would happily accept, this patient for a lot of reasons, but really for intracranial monitoring is one of the biggest ones. Permissive hypotension in this patient is absolutely inappropriate. So this is candidate number one that I say throw vasopressors on. If you have a trauma surgeon on your left and a neurosurgeon on your right and a TBI patient, listen to that neurosurgeon when they're talking about blood pressures. So it's my thought. So again, Levophed is generally what we're going to use at UVA. The second one you guys are probably familiar with, spinal cord injury. You've lost your sympathetic tone and you're in this pattern of neurogenic shock. Again, you want to drive that pressure high, and they're going to keep it high for quite a few days. Norepinephrine usually is preferred medication too. And things that we talked about, rapid sequence innovation. As a toxicologist, I could talk about medications all day. But when you're thinking about like what medication you're going to give somebody for intubation, or if they come up into your ICU and you're going to put them on some Versed or some propofol, pressures might drop. You might give them a little bit of Levophed, Epi, whatever one you specifically prefer. So kind of where are we now? Again, ATLS does not like to make really specific statements aside from rapid sequence intubation, TBI, and spinal cord injury. Stay tuned. That might change over the next 5 to 10 years. But if you go through the other kind of big guidelines associations, especially the European ones, they're a little bit more willing to offer some form of guidance, whether it be, vasopressin, norepinephrine, but those would probably be the two biggest ones that I would start with. Personally, I would start with norepinephrine on these patients. All right, so kind of like, a practical approach thinking about this. You have a trauma patient in shock. Again, ATLS wants you to control that hemorrhage. That is the most basic thing. If you have a hose that's leaking, you're not just going to leave the faucet running and try to crank more water through it. You're going to try to close off where it's leaking. You've given them blood and they're still hypotensive. So I think vasopressor is absolutely reasonable in that candidate. If you have a TBI, spinal cord injury, again, it is bad to not give those patients vasopressors. That is absolutely indicated in those. And then just kind of the basic ones, norepinephrine, vaso, push-dose epi, all completely reasonable.
So when you were looking this, did you look at push-dose vaso, or was there any evidence kind of for or against push-dose vaso?
Not really push-dose vaso. There's not a whole lot of evidence for push-dose things in general, but not that I could find for push-dose vaso.
Sure.
Yeah.
Okay.
So let's get back to our patient. You've got this patient with a severe TBI. You guys saw that CT scan, and if for some reason you missed it, it was ugly. There's blood multiple places. He's got, a nice young brain that has no room to swell, and he is starting to herniate, right? He's in hemorrhagic shock. He's bleeding from somewhere. You've given him blood, and you can't figure out where exactly he's bleeding. So ATLS, what they're going to tell you, keep on giving him blood products and figure out where he's bleeding from. Vasopressors are not going to be the primary therapy, right? Again, however, we're going to take a step back and say, I think that this patient is absolutely a candidate for a little bit of norepi, especially as you're intubating them during this situation. So what I would do in this specific case, again, like I mentioned, keep on giving him blood, pelvic stabilization, figure out if he needs to go to the OR or interventional radiology, secure his airway, and then start him on some low dose norepi. The biggest argument for this is, the bottom right one under Y. So severe TBI, remember your perfusion pressure of your brain is your MAP minus your ICP, and you really have to make sure that you are perfusing your brain. So that is by far and away the biggest takeaway I think that everybody should walk away with.
Yeah, organs you only have one of. You got to kind of value.
Yep.
All right.
Yeah, so we really talked about all these things so far. I don't really think that we need to really go through them again. But again, stay tuned. If you redo ATLS, you're not going to hear much about vasopressors. But if you want to dig into the literature, there's plenty of literature that says that vasopressors are okay in trauma patients.
Yeah, and when we teach ATLS, kind of that, there's that very reasonable and very explicit acknowledgement that this is what the curriculum is, this is what the college endorses and teaches, and oh, by the way, you may consider, but this is beyond the scope of the course.
Yeah.
So,
Yeah.
You know, if you ever join us for one, happy to have you. We'd love to, and we're happy to talk kind of about these things. But you know, I think realistically, the biggest thing that we'd love to say is thank you for having us. Thank you for your attention. Hopefully this is a little helpful. Hopefully, you know, a little bit of the why we do what we do. And you know, that being said, we're gonna stop sharing, and we're gonna stand by for any thoughts or questions or final things. And you know, we're also gonna apologize for my poor Wi-Fi signal and intermittent connectivity. Over.
Great job. Are there other questions from anyone on the call? This has been a really almost fun type thing. I think that you guys may need to start a podcast. The ABCs of trauma I mean, it's terrific, and it just is a wonderful, different sort of format for us that I think is really, really, really a great way to do it. There are so many pearls rolling around on the floor that that you folks shared with us. That if you're listening, you say, "Oh wow, I need to write that down." Or back in the day when we wrote things down. I will give you one personal note. I have had both a large bore chest tube placed and a pigtail, both of which I was totally conscious with a spontaneous pneumothorax, totally just laying in the ER, and there is no comparison. The big bore tube is undoubtedly the worst pain I've ever experienced in my life, and it was done by a very caring physician. On the other hand, I felt absolutely nothing when the pigtail was placed a few days later, because the first one worked its way out. So if the patient input has any point, to go through the pigtail, just as you recommended, definitely.
Well, I'm sorry I had to go through that, but you know, it absolutely supports, you know, what everybody else is saying. So.
Oh yeah.
I'm like Dr. Burns. I have now been the recipient of a total of 4 chest tubes. Not many people can have that a bit. Some just popped up from Dr.
All right. So the question is, for vasopressin at UVA, is it a titration or a set rate? We currently have it built in for sepsis dosing only at a set rate. I don't know what the answer is on the floor. What I do know is that we are very fortunate to have pharmacists in our ED, and that those pharmacists are actually really wonderful people to work with. They're flexible, and they actually are more than willing to cite evidence and studies as we go. I don't give enough vaso that I've had these arguments. I've had a couple of kind of ongoing set rate infusions. I have not yet titrated it. I think what I do is I'll kind of lay it on and titrate the other stuff to go with it.
Yeah, I've only done a set rate, but luckily for us, we have a guest speaker that's walking in. This is my partner, who is a neurocritical care physician at UVA. Ashley, the question, this is Dr. Graziano.
Hi.
The question is talking about vasopressors.
Yes.
Vasopressors. And again, so neurocritical care doc at UVA, so she uses vasopressors a lot. Do they use a set rate, or do they titrate for vasopressin, do you know, on most of the IC floors?
Typically, we use a set rate.
You're using like 0.04.
Yeah.
Yeah.
Mm-hmm.
Yeah.
Yep.
Does that help, Dr. Crawford? All right. I'll assume the answer is yes. All right. Michelle Mitchell says, we have blood components in the ED, not whole blood. It takes a while for the FFP to, yeah, oh, that is such a problem. And we've always kind of had that same problem where plasma just takes a while to defrost, especially in frozen. Ironically, I was on a deployment in a foreign, very hot environment. And I had to get that FFP defrosted by the time we hit the target. And I will tell you that keeping that plasma frozen right up in your axilla is the best air conditioning I could get in that entire. It's probably the only time I was actually comfortable that entire deployment. Would you recommend anything while waiting for FFP? Yeah, so we actually are giving PCC with, I'm trying to remember the exact ratio. I am going to beg your forgiveness. I think we're doing it every 5 pack of red cell equivalent and or whole blood, just because of concentrate degradation or dilution over the course of resuscitation. I have to be honest, and this is kind of an artful question as you talk about fractionated component therapy. And again, not a fan, but if you are, my point in fractionated therapy, and I'll give this to the residents, is you got to pick one to start first. My money's in the plasma anytime, right? Mm-hmm. We're treating hemorrhage. So you plug the hole, you got to get them the factors, you got to get them all of the other things that support their actual stopping bleeding. Mm-hmm. Red cells and oxygen carrier. And now, again, clinical scenarios vary, but oxygen carrying capacity in young, healthy people is not generally your immediate life-threatening and primary problem. And if you've ever done a thoracotomy and felt the ventricles completely collapsed and flaccid, you recognize that part of the problem is simply the filling of the tank with whatever fluid is there. So yeah, I'd certainly give the PCC, Kcentra, pick your brand name as you see fit or what you've got on your formulary. But man, my money is on the FFP, and I really love not having to have frozen FFP that we got to then defrost and screw around with. That really bothers me. But yeah. Thoughts?
I don't have anything else beyond that.
All right, easy day. All right. Hopefully that helps, ma'am. All right, easy day. Final questions. Standing by.
Speak up or put it in the chat. Okay, it looks like I don't see anything else unless Vinay is seeing anything else.
Please clap your hand.
No, they're just saying thank you.
Okay, thank you. Thank yous are welcome. We want to thank both our speakers, Dr. Byrne, Dr. Kearns, for doing this. This is a unique opportunity for our care team here to have access to two such experienced individuals and people that really take care of these seriously ill patients every day. My special thanks to Dr. Michelle Mitchell, who's on the call with us. She, as well as her co-team director on the Martinsville campus, Bruce, so they basically were instrumental in organizing this program tonight. And Dr. Mitchell, I thank you for your leadership and help in doing that. For everyone else, let me remind you that on July 12th, a Thursday evening, we will have the program on screening for colon cancer with an emphasis on which of the newer techniques may be as good as an old-fashioned colonoscopy. So I hope you'll plan to join us. We do not have another program in June. It's the time for our new residents to be coming in and our old residents moving on to fellowships in the real world. So the next program is not until July. That being said, thanks to everyone for being on the call. Thanks to Vinay for managing the call in the back room, as we would say, and to our speakers. Please have a great night. We look forward to seeing you again. Take care. Bye-bye.
Thank you all.
Yeah, thank you guys for having us.